Good afternoon, everyone. Thank you for joining us today for Beneath the Masks, Men, Masculinities, and COVID-19 Disparities. I'd like to first thank you for coming to the first in a series of conversations around holding space for boys and men of color, reimagining masculinities, transforming systems, and advancing health equity. This conversation is being co-sponsored by the Society for the Psychological Study of Men and Masculinities, APA's Division 51, and the American Psychological Association. Before we proceed, I'd first like to introduce you to our speakers. I am your host, Dr. Wizdom Powell. I serve as the director of the Health Disparities Institute and am Associate Professor of Psychiatry at the University of Connecticut. I am also the president of the American Psychological Association's Division 51 and an honorary professor at the University of KwaZulu-Natal in Durban, South Africa. Next, I would like to introduce Dr. Ron Levant, who is currently Professor Emeritus of Psychology at the University of Akron, where he served as Dean of the Bucktail College of Arts and Sciences from 2005 through 2009. He also served as the 2005 president of the American Psychological Association and as editor of the Psychology of Men and Masculinity. He has authored and co-authored, edited or co-edited 19 books and over 250 peer-reviewed refereed journal articles and book chapters. Most recently, he's co-authored The Tough Standard, The Hard Truths About Masculinity and Violence. Welcome, Dr. Levant. Next, I'd like to introduce Dr. Joel Wong. Dr. Wong is a professor of counseling psychology and chair of the Counseling and Educational Psychology Department at Indiana University. He's a fellow of the American Psychological Association through Division 17, 45, and 51, and of the Asian American Psychological Association. His research interests are in the psychology of men and masculinities, positive psychology, and Asian American mental health. Dr. Wong is extraordinarily accomplished and has co-edited 2 books on men and masculinities, including numerous publications, peer-reviewed publications and journal articles. He is also the associate editor for the journal Psychology of Men and Masculinities. It gives me great privilege and pleasure to introduce Dr. Derrick Griffith, who is a professor of medicine, health, and society, and the founder and director of the Center for Research on Men's Health at Vanderbilt University. Dr. Griffith also has affiliate appointments in American Studies, Health Policy, Human and Organizational Development, and Sociology at Vanderbilt, and he is the chair of the Tennessee Men's Health Report Card. Dr. Griffith has made tremendous contributions to the field of advancing men's health equity. His research has been featured on NPR, Ebony, Time, USA Today, and in numerous other national media outlets. In addition, he has co-authored numerous peer-reviewed publications and most recently co-edited one of the first volumes on men's health equity. Last but certainly not least, we'd like to introduce Dr. Brian Smedley, who's the Chief of Psychology in the Public Interest and Acting Chief Diversity Officer, where he leads APA's efforts to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. He's a national thought leader in the field of health equity. Currently, or actually formerly, he co-founded and served as executive director of the National Collaborative for Health Equity, a project that connects research, policy analysis, and communications with on-the-ground activism to advance health equity. His numerous accomplishments, and we're so proud and privileged to have him share the panel with us today. I'd like to do some level setting before we start our conversation to help you understand why we're here today having this conversation at this time. As many of you are aware, in several states across the US, data are emerging to suggest that death rates from COVID-19 are highest among men. And these data and findings are consistent with the often cited mortality-morbidity paradox, which has documented that even as sex differences and life expectancy gaps narrow, males in the US continue to live shorter lives than women and have done so consistently since the 1980s. We also know that if we drill down to subpopulations of men, we see disparate outcomes with respect to life expectancy. Particularly, we notice that Black men live the shortest lives of all individuals in US society, and that's despite medical innovations and policy advancements. We also know that these findings, both those related to COVID-19 life expectancy and mortality, and those attributable to general life expectancy, also may be rooted in biological processes. So we lift up for your consideration that some of what we might be describing today may be attributable to the fact that males start out with a so-called survival disadvantage that begins at birth. That some have cited that males have shorter lives because they only have a single sex chromosome. Others have noted that men have less connective tissue response to sex hormones, which creates less resistance to oxidative damage and greater suppression of immunity. And more importantly, we are starting to see emerging data to suggest that men have greater telomere shortening than women, which increases their susceptibility to rapid biological aging. But we also want to call your attention to one point, and that is that if these findings were solely rooted in biology, then we might see similar rates of COVID-19 disparities among men across all racial and ethnic groups, and that is not the case. And so today, in addition to holding and lifting up the potential biological explanations, we're also going to explore the role played by masculinities and other intersecting psychosocial factors. When we're talking about masculinities today, we're referring to those shared cultural expectations or standards about how males should behave. We also want to make it plain that we understand that masculinities are multidimensional, plural, and situational, that they're precarious and failure prone. And of course, that while there are personality and biological embeddedness of some aspects of masculinity enactment, we recognize that many of the standards and shared cultural expectations are socially constructed. Those messages that men and boys receive across their life course, like boys don't cry, walk it off and take it like a man, are also operating in tandem with other broader biological factors to produce a perfect storm of potential disparate outcomes for men and boys. We also lift up today data documenting that even as we talk about men and boys as a whole, that there are subpopulations of men and boys that are at greater risk for COVID-19 disparities. And we are seeing data emerging across the country to affirm that, in fact, there's disproportionately higher impact of COVID-19 on racial and ethnic minority communities. And as we think about these communities of color as a whole, we want to lift up that the possibilities for exposure are more pronounced for individuals in those communities because they live more often in so-called viral hotspots and represent a higher percentage of our essential workforce. We also draw your attention to the potential psychosocial impacts, and we'll be talking and unpacking those in today's conversation, because we know that the physical distancing requirements have meant that many men and boys and women and girls that are connected to them are now more socially isolated and therefore at greater risk for potential depression, upticks in behavioral health issues, and trauma. And finally, as we talk about boys and men of color and racial and ethnic minorities, men and boys as they're affected by COVID-19, we want to make it clear that this is not a zero-sum game. That in fact, the disparities that we're laying out today have significant implications for our entire nation. Health disparities have direct costs on healthcare spending and indirect costs on worker productivity and income. So when boys and men perish prematurely from COVID-19 and other health conditions, we all suffer. And with that introduction, I'd like to invite Dr. Ron Levant to give his next presentation. Thank you.
Okay, and turn on my camera. Okay. Can I have the next slide, please? Okay, so as was mentioned, there are sex disparities in COVID-19. Men are dying at a higher rate. In the US, the death rates are 58% men, 43% women. These mortality disparities are related to gender differences in the severity of the illness. Both disparities result from both behavioral and biological factors. My talk is going to focus on the behavioral factors because much is known about them and behavior can be modified. I hope that by highlighting these health disparities, I will encourage men to change their behavior and follow the CDC recommended practices of wearing a face mask, avoiding touching one's face, frequent hand washing, and social distancing. Now, what is the role of masculinity in health behaviors? First, let's define what are some of the masculinity norms. Restricting the expression of vulnerable and caring emotions is one of them. Being tough and dominant, taking risks, avoidance of anything that hints of the feminine, self-reliance, and having a strong interest in sex or being a playboy. And all have a clear conceptual linkage to taking health risks or avoiding health promotion. Some men don't take the steps to stay healthy, such as having regular medical checkups, eating healthy diets, because these things may appear feminine or unmanly. Men who endorse the avoid femininity norm are likely to visit a doctor or nurse only when their condition has become severe. And men who conform to the self-reliant norm may be reluctant to ask for help about a medical condition because it could cause them to feel weak and unmanly. Next slide, please. Now, talk about morbidity and longevity disparities and health behaviors. Men have greater morbidity than women. Under the age of 65, they're at higher risk for heart disease and lung, bronchus, and colorectal cancer than women. 6.8% of all males die from injuries, unintentional injuries. However, 42.3% of men ages 20 to 24 die from these injuries. And this remains the number one cause of death in men until age 45. And men also have higher rates of infectious diseases, mostly due to HIV, AIDS, suicide, and liver disease due to alcohol abuse. Men have higher mortality rates than women for 14 of the 15 leading causes of death, which is now 5 years. Health risk behaviors account for 40% of the mortality rates, irrespective of sex. So what this means is regardless of your sex or gender identity, if you engage in certain health risk behaviors like smoking tobacco or not wearing seatbelts, you're at elevated risk for death. Health behaviors tend to be associated with femininity, and health harming behaviors are linked with masculinity. Will Courtney, a member of Division 51, observed that American men tend to engage in more than 30 controllable behaviors that increase their risk for disease, injury, and death. They spend less time with their physicians, engage in fewer preventative health behaviors, consume more alcohol, use more tobacco products, take more risks, have poorer diets, poorer sleep hygiene, poorer weight management, and lower physical activity than women. In summary then, men's greater mortality from COVID-19 parallels their greater mortality overall and is likely linked to their poorer health practices. What happened to the slides? Yes, racial ethnic disparities. Can we get that one? There we go. No, racial ethnic disparities. There we go. Black American men have a higher risk for certain physical illnesses, such as hypertension and sickle cell disease, than white American men. Environmental component is huge in this. If one does not live near resources like gyms or stores that sell healthy food, i.e. in a food desert, as many inner-city Black neighborhoods are, one may be more likely to use negative coping mechanisms like eating foods high in salt and sugar, or substance use, which can contribute to greater physical health concerns. And additionally, of course, experiencing racism is very stressful, and stress creates physical health concerns. Latino men have higher rates of illness, particularly diabetes and cancer, than white men. There are general health disparities that put men of color at greater health risks than white men. According to the Kaiser Family Foundation, people of color and low-income individuals are more likely to be uninsured, face barriers to accessing care, and have higher rates of certain conditions compared to whites and those at higher incomes. In terms of COVID-19, which we know primarily affects the lungs, many people of color and low-income individuals live in neighborhoods that have higher levels of pollution, which would cause lung damage. And as has been mentioned, there are race disparities in COVID-19 deaths. Nationally, African-American deaths from COVID-19 are nearly twice what they would be expected based on their share of populations. And in 4 states, the rate is 3 or more times greater. In 42 states plus DC, Latinos make up a greater share of confirmed cases than their share of the population. In 8 states, it's more than 4 times greater. Next slide, please. Next slide, okay. Masculinity and men's health behaviors. What does the research show? So Jim Harrison, long ago in 1978, very presciently warned that the male sex role may be dangerous to your health. However, since then, the picture has become more complicated. Early studies focus on masculinity's relationship to alcohol use and the anti-femininity masculinity norms. More recent studies have examined a wider range of health behaviors in relation to using diverse groups of men, and several studies have investigated masculinity and diet. Other studies have found, paradoxically, that masculinity may be a two-edged sword associated with both health risk and health promotion. One review reported that gender role conflict was directly associated with men's risky health behaviors, but traditional masculinity ideology was negatively associated with those behaviors. Another one found that conforming to playboy and risk-taking norms were predictive of greater alcohol use, while endorsing the emotional control and heterosexual self-presentation norms were related to less alcohol use. Levant and colleagues found that some masculinity factors were associated with health risks, but others were linked to health promotion. In 2011, that team concluded the relationship between health behavior and masculinity depends on which dimension of health behavior one is predicting and which facets of masculinity one is using as predictors. These links between masculinity norms and health behaviors and outcomes have been at least partially replicated with a larger, more diverse sample. The team in 2014 noted the vast majority of findings that were replicated were risk factors, suggesting that traditional masculinity is more of a risk than a buffer, and occurred in the analyses involving anger and stress and avoiding substance use. Next slide, please. Nope. Masculinity, stress, and coping. Isn't there another slide? Well, masculinity, stress, and coping. Stress has a monumental influence on health. In fact, it's been found to greatly contribute to men's higher mortality rates. Masculinity norms create a lot of stress for men. These norms encourage men to be breadwinners and initiators, always ready for sex, and tough protectors, while bringing pressure to not show their emotions or vulnerabilities and not being allowed to receive emotional support. That's why we call masculinity the tough standard. When life gets difficult, men influenced by masculinity norms are also limited in their coping strategies. Coping mechanisms that are beneficial to health, such as meditation, yoga, crying. Yes, crying and asking for help are often off limits to men because they appear feminine. Furthermore, some men may be unable to put their inner experiences into words. They're alexithymic. Instead, such men might be more likely to use substances, eat unhealthily, use tobacco, and engage in risky behaviors like having unprotected sex. To summarize then this presentation, men's greater mortality from COVID-19 parallels their greater mortality overall and is likely linked to their poorer health behaviors. One urgently needed study is the comparative compliance of men and women with the CDC recommended practices and the link with other factors like masculinity. While masculinity is linked with many poor health behaviors, it is also linked with a smaller number of health promoting behaviors. And there are only a few studies on masculinity and current health status, and those that exist have found opposite results. So to conclude, I think we really need to look at men's behavior during the current pandemic and encourage men to give serious attention to following the recommended practices. Thank you very much.
Thank you so much, Dr. Levant. We greatly appreciate all of the foundation you've laid for us, and we're excited to invite our next speaker to the panel stage. I'd like to invite Dr. Joel Wong, who's going to talk to us about the intersectional prototypicality model, implications for men of color. Dr. Wong.
All right, I apologize for that short delay. Let me do a screen share. Let's see. Let me just try to share the screen again. Not sure why the screen share is not working.
We actually can bring up your slides for you, Dr. Wong. If you would stop sharing, we will do that for you, on your behalf.
Okay, let me. Okay, why don't you do the screen share for me on my behalf? Sorry for the.
No worries whatsoever. These things happen. We will absolutely take care of that. If you can stop sharing, we will share our screen. Thank you.
Okay, you know what? I think it's, wait, hang on. Let me try it again one more time. Which screen was that? Let me just give me another chance to try it.
Absolutely.
Okay, you seeing my screen?
We do.
Okay. All right, I think it worked. Okay, thank you for your patience. I appreciate it. We are actually still on time.
Yes, we are.
We are. So I want to be able to talk today a little bit about a new conceptual model that my colleague, Keiko McCullough, and I have developed. This model is called the Intersectional Prototypicality Model. And we developed it to help explain the experiences, the discriminatory experiences of women and men of color, especially for Asian Americans. If you want to know more about this model, it's currently under review in a peer-reviewed journal, and I'll be happy to share more details with you. In the interest of time, I won't have time to be able to provide all the empirical evidence supporting the model. I'm making all kinds of assertions, and there's no time for the empirical research, but we're happy to chat more if you are interested. I'm going to be talking mostly about the model, and in my last slide, we'll talk about the implications for COVID-19. So bear with me if you're like wondering, wait a minute, how is this going to be relevant to COVID-19? We'll get to that. But to emphasize, the model focuses not on health, but on the discriminatory experiences of women and men of color. So we're trying to explain the nature of discrimination, the nature of racism and gendered racism experienced by women and men of color, all right? So let me begin with this concept of prototypicality. I didn't make up this word, it's found in the social psychological literature. And one way to think about prototypicality is to ask yourself, close your eyes and imagine for a minute, what comes to your mind when you think of a surgeon? And if you're like many folks, what would come to your mind, or our minds, would be that of a man, particularly a white man. And so we would say that a white man is prototypical of a larger social group known as surgeons. And so prototypicality is the extent to which a person or a subgroup is perceived to be representative of a social group or a role. So it's very important to understand this is all based on perceptions. It may not be about reality, right? If you do the same thing, close your eyes and think about what comes to your mind when you think of a typical American. And for many folks, what's going to come to your mind is that of a white person. And therefore, we would say that white people are prototypical of the larger category called Americans. So with this understanding of prototypicality, I wanted to introduce two other concepts. So hyperprototypical means that you are perceived as less representative of a social group. So if you're hyperprototypical, you are the opposite of being prototypical. So in a way, women are hyperprototypical of the social group known as surgeons. Now there's another construct that we're proposing, and that's hyperprototypical. So to be perceived as hyperprototypical is to be seen as having exaggerated or excessive attributes of a prototypical member. So it's important to understand hyperprototypicality is not the opposite of hypoprototypicality. They're both, hypo and hyperprototypicality are both viewed as deviant forms of prototypicality. So the group or the person who's viewed as hyperprototypical is seen as a caricature, is seen as it almost in a way superhuman or abnormal in a very exaggerated manner. All right. So bear that in mind as we think about the consequence of hyperprototypicality. So we argue that both hypo and hyperprototypicality shapes the nature of discriminatory experiences against women and men of color. How does that happen? Well, it happens in terms of looking at the congruence between gender and racial stereotypes. So let me give you an example from the experiences of Asian American men. Men in general are stereotyped as masculine. Men as a gender group are stereotyped as masculine. On the other hand, Asian Americans as a racial group are stereotyped as feminine. And that's pretty clear from the research for both men and Asian Americans. And so there's this incongruence between the gender and racial stereotypes, and that, we argue, engenders hypoprototypicality among Asian American men. So Asian American men are not seen as representative of the Asian American racial category, and they're not seen as representative of the male gender group. And there's quite a bit of research supporting these assertions. In one study, when participants were asked to write about a typical Asian American, they would start writing about an Asian American woman rather than an Asian American man. And so that's, again, an example of that hypoprototypicality. Now, what about hyperprototypicality? And this is where I think African Americans are provides a good example. Men are stereotyped as masculine. African Americans as a racial group are stereotyped as masculine too. And so there's that mutually reinforcing racial and gender stereotypes. And we argue that when there's that mutual reinforcement of gender and racial stereotypes, it produces hyperprototypicality for men of color. And so we argue that African American men are often seen as hyperprototypical of the male gender group. So if men are seen as masculine, as macho, or stereotyped in that way, African American men are stereotyped as hyper masculine, hyper macho, and with all the stereotypes associated with men increased and multiplied to a heightened level. So what are the consequences of hyper and hyperprototypicality? Well, we argue that the consequence of hyperprototypicality is marginalization. It's important to understand what marginalization means. That it's a form of discrimination that's characterized less by active discrimination, but more by the omission of positive acts. So if you experience marginalization, you tend to be experiencing discrimination in a form of invisibility. You're just unseen, you're unknown, you're absent, you're not given attention, you're not worthy of attention, all right? And so a classic example of marginalization would be that you're just invisible in the mass media. You're not seen as worthy of attention. You're not seen as representative of your group. You're not seen as attractive. You're sort of in the background. The consequence of hyperprototypicality, we argue, is dehumanization, where you're seen as in some ways less than human or not having full human qualities. We distinguish between two different types of dehumanization: animalistic dehumanization and mechanistic dehumanization. Animalistic dehumanization, we argue, is more relevant when a social group is viewed as being of a lower status, and the research shows that animalistic dehumanization involves being stereotyped as having animal-like qualities, lacking rationality, lacking self-control, lacking intelligence. And if you look at the research, those are the stereotypes that have been assigned to Black men. And so Black men, as a consequence of hyperprototypicality, we argue experience dehumanization in the form of animalistic dehumanization. I'll end with this kind of implications for COVID-19. If you look at this picture there of an Asian man this is a picture of someone who experienced a hate crime as a result of COVID-19 racism. And this is, it was in the news of this man who was brutally attacked by other folks who shouted racial epithets related to COVID-19, because somehow people of Asian descent, especially anyone who is perceived as being of Chinese descent, although folks often can't distinguish between various Asian American ethnic groups, but people of Asian descent are viewed as being the carriers or the originators of the COVID-19. And so this has happened, this is terrible, but I would argue that it hasn't really been given the kind of media attention that I think it deserves. That in the midst of all kinds of different news, the discriminatory experiences against Asian American men has been given insufficient attention because of the experience of hyperprototypicality, which results in marginalization. And I think that's a problem. That's something we need to speak out on. What about for African American men? I would argue that their experiences of animalistic dehumanization results in a number of negative consequences. 3 in particular. The first is that Black men invokes fear in others. If you're seen as somehow superhuman, animalistic in some way, you're viewed as dangerous. This explains what happened to George Floyd and many other African American men who have suffered police brutality, how else do you explain why a police officer would place his knee on the neck of an African-American man for 9 minutes? If this person is not viewed as someone who is dangerous, I need to subdue this person, it's dangerous in some way that I have to be very, very fearful of. And that to me is a form of animalistic dehumanization. Number two, you are not likely to perhaps receive as much medical attention if you're viewed as in some ways less than human. Could this be a contributing factor to COVID-19 health disparities? And I raised that as speculation without empirical evidence, but something to consider. Number three, the research shows very clearly from the May report from the Department of Labor that unemployment has surprisingly gone down in the month of May, except for African Americans. Unemployment has actually gone up. And so African Americans suffer from COVID-19 disparities and unemployment. Why is that the case? One factor I want to put out there is that if you're treated as somehow less than human, African American men suffer the consequences of unemployment. You're the first to go and you're the last to be rehired. So I want to present some of these concerns for us to consider as we think about men of color. Thank you.
So much, Dr. Wong, for giving us such an insightful and critically relevant framing for understanding disproportionate COVID-19 disparities among subpopulations of men of color. I especially appreciate you lifting up the issues that are facing Asian American men around the perception that they embody the virus. And so I think you really helped our audience understand and level set for us how to think about those issues. I'd like to now invite Dr. Derrick Griffith to the panel stage, who's going to talk to us, and I think, link even perhaps some of what we've just heard really nicely into his conversation about Black men and COVID-19, the case for a new frame. Welcome, Dr. Griffith, and thank you for being with us.
Thank you, Dr. Powell. Okay. Well, good morning. Well, good morning still my time. Good afternoon to those of you further east. Yeah, let me pick up actually with where Dr. Wong was and try to incorporate some of that into my brief remarks today before we get to the larger conversation. I do want to center and focus my remarks on Black men. Both Dr. Levant and Dr. Wong have done a great job, as well as Dr. Powell, in setting the stage. So I'm going to skip a couple of things that I sort of plan to talk about and just get into the case and this concept of a frame and how we think about it. So there's this idea that really came more out of sociology of the way that you frame a particular problem. And I think this is, underlying the principles of what Dr. Wong was sort of laying out in his beautiful new conceptual model around intersectionality, is this idea of what's viable, meaning the kinds of things that are salient and the ways that we explain things and how consistent are they with our cultural beliefs, values, and so forth. And that the way that we explain those kinds of things, if those concepts and the explanation that you have is consistent with your cultural beliefs, your values, the kind of the culture of the times, then you don't usually question it quite to the same degree that you might in other cases. That doesn't speak to the validity of that frame, which is actually what's to the degree to which it's actually true. And so you have this tension a lot of times when we're trying to explain problems like disparities, when you're trying to explain disproportional care, disproportionate outcomes, how do you explain those differences? And so, we know that there's been a lot of attention to looking at the biological reasons that men are dying younger or dying more of COVID. We looked at the biological reasons as to, are there sex differences? Again, biological difference as to, for African-American men, there's been this constant look for different things related to African-Americans that are consistently associated with being Black, that explains the racial disparities that we've seen in life expectancy, in rates of morbidity from various diseases and so forth. But we struggled to come up with something that actually explains it, that is both valid and viable in our larger society, and we've more leaned to what's viable than what we have to what's valid. So when we have the case of, say, a Gary Fowler, who had done all the right things. So we were talking, Dr. Levant was talking about, the different things that we are encouraging men to do, and that in some ways may be sort of seen as representative of masculine sort of values, and other ways are seen as sort of countering or the negative side effects or negative effects of the ways that we sort of embody different versions of masculinity. He did what he was supposed to. He went to the doctor, he experienced some symptoms, he kept going to the doctor, and actually very persistently went to the doctor to try to get help, and was consistently turned away. And, the question is, was he turned away because he's Black? Was he turned away because he's male? Was he turned away just because he's in a, an environment where folks just don't really get good quality care? And so it has nothing to do with race or gender. It just happens to be, something about the neighborhood and the context in Detroit where he was. But how do we understand these biases and so forth is part of, and how do we explain that? And therefore that will dictate what we decide to do or not do about those kinds of issues. We also know that efforts that Black men have, again, in trying to do the right thing, don't have the same benefits or have the same context for making those kind of choices. So when you have to make a choice about whether or not it's safe for you to wear some kind of protective mask when you go out in public, and what does that mean for you? Again, that's a really difficult choice. And we've actually seen this even with medical providers. This is a story that was out about a doctor who's more afraid of, wearing his face mask in public because of the difficult role that what that means, and being afraid of people being afraid of him and what they may do simply out of their fear and not understanding that all he's trying to do is do his job, simply walk around and be, himself, as opposed to really trying to do anything menacing or fearful and so forth. So there's this context of, and this is the whole understanding of racism, is it's when you're trying to do the right thing, but it doesn't have the same benefits. So they're actually trying to go get care, they're trying to protect themselves, they're trying to protect others from whatever things that they may have, but we're trying to do these kinds of things in ways that don't have the same benefits or actually have unintended consequences, or consequences that we're quite aware of that are going to potentially be adverse, that we have to pay attention to and consider when you're trying to do the right thing. And so we've looked at this, again, conceptually through this lens of intersectionality and men's health for a number of years, and tried to look at, well, how do we understand why each factor comes, plays a role in this, and then what do we do with that? And so I've used this model. It's an adaptation of another colleague, Tom Levise's model that he had some years ago, trying to explain racial disparities in health outcomes. And I've used this to try to look at racial disparities in men's health as well, and particularly try to figure out how do we conceptualize Black men and Black men's experiences. And we know that this combination of appearing to be Black and male, again, regardless of what your actual identity is, but how you appear to others, has an implication for how you're going to be received in society and so forth. So there's these tensions sometimes between, how you appear to others and how you may see yourself. And a lot of the social experience, a lot of the stressors that we pay attention to or that we recognize is really about this combination of the exposure to stressors that come from looking Black, and this combination of being male, that that there are things you're going to anticipate or you need to anticipate dealing with. And whether or not you actually experience them, you have to be prepared for them. So there's these older concepts, excuse me, in the psychological literature about armoring. This is the whole concept of vigilance, or the principle behind the concept of vigilance, where you're preparing yourself and you're working your body up to deal with these kinds of experiences. Whether or not they actually happen, your body has still had to respond, and it's still wearing down in the same way. You're still having the same weathering patterns that we're seeing and understanding and experiencing. And so this question of why, and I'm going to close with this, is really the fundamental question to me. How do you understand when people are doing the right thing, when we see in these disparities, how do you understand the disparities that we're seeing in outcomes, in mortality in particular, when we're seeing roughly the same rates of infection, but men are dying at considerably higher rates, when we don't have the data to support being able to look at the intersection of being, of a particular race and of a particular sex, and look at that sort of race by gender and sex sort of intersection, and how do we make sense of that? So we're limited in what we can do, and we're left to extrapolate from these different factors about the mortality and how do we explain those different factors. Yet we have to try to do the best that we can with these different data sources and look at how, use the frameworks like Dr. Wong's to potentially explain these factors. So the last thing I'll say is connecting it particularly to just what his model. I would actually propose that there's a contextual part to the model that Dr. Wong was just describing, because I would argue that he was, the hyperprototypical of actually men going to the doctor, him actually seeking screening and so forth, that Black men in this context are both seen as sort of hypoprototypical as well as hyperprototypical when you're thinking about the types of things that need to happen as it relates to you going to the doctor or taking care of yourself in this context of COVID. So you may be seen as more fearful, even if you're doing the things that you're supposed to, like wearing a mask, like going to the doctor. But because you're such an anomaly in that space, that it seems like when you actually go to the doctor, that people aren't taking you seriously. And we know that Black men tend to have a lot of negative experiences when they go to the doctor, regardless of whether or not they're actually trying to do the right thing. So I look forward to our conversation. So thank you.
Thank you so much, Dr. Griffith, for such an important and compelling reframing of the issues facing Black men in COVID-19, and for drawing those really important connections between Dr. Wong's presentation and the issues we're talking about now. I'm going to start the next conversation by talking about an issue that we lifted up in the beginning of our overview, and talking about the confluence of the pandemic with other sort of social or psychosocial factors that are facing boys and men of color. And I'm going to see if I can do this without, let me escape here. Oh, current slide. Let's see. We've been getting some really interesting conversations going in our Zoom chat room, and we have some questions that have been raised on our Facebook pages, and we will be attending to those shortly. So thank you for those who have engaged with us in this dialogue. So I'd like to remind us of Ava DuVernay's most riveting documentary series, When They See Us. And it's an important frame to think about how we discuss and describe the supports that boys and men of color might need amidst the COVID-19 pandemic. We've all recognized that as we are facing the very real threat of a virus like COVID-19, there's also a shadow pandemic operating in the background related to exposure to racism. And so the title of my remarks is When We See Them, Optimizing Racial Trauma Support for Boys and Men of Color Amidst the COVID-19 Pandemic. Many have lifted up the fact that COVID-19 in of itself is a trauma pandemic in the making. I'm especially drawn to this quote by Dr. Michael Salas, who pointed out that our society, as we are preparing for all of the measures related to contact tracing, testing, and PPE, that our society also needs to prepare for the psychological impact of COVID-19 that it is likely to follow. When we talk about trauma in this context, I need to level set with a couple of definitions. First, we all know that the DSM-5 has very specific criteria for trauma, and they define it as a threat, exposure, or direct witnessing of death, injury, and/or sexual violence, repeated exposure to a traumatic event, divorce, loss of a loved one, and others. And they really sort of confine, if you will, the definition of trauma to traumas that are erupting as a result of direct experience. But we know that traumas, as injuries or wounds to the spirit, can also occur as a consequence of secondary trauma or vicarious trauma, the trauma that occurs just as a consequence of your bearing witness to the threat or injury or potential injury to those you love and care for. We know that there are also gender differences in trauma response, such that on average, we see that men tend to fight or flight, in the face of trauma use problem-focused coping rather than leaning in for support, will withdraw from social support. And we also know that there are differential activation of our hypoarousal systems by gender, such that we can sometimes see more irritability, angry outbursts, and impulsivity when men and boys are exposed to trauma. We also know that masculinity norms actually sanction the ways that men respond to trauma. Men are socialized, as we've been discussing, on average to value the display of physical and mental toughness, and the pressure to be a man about it can impact trauma reporting. We know that men, on average, as Dr. Levant pointed out, who endorse more rigidly those stereotypical masculinities can have more poor outcomes on average. In other words, masculinity norms can impact trauma reporting and can encourage men to silence or suppress the trauma experience. But there are also significant systems level gaps in our capacity to listen to and respond to the distress signals that boys and men of color send. Some of our challenges with responding to particularly Black boys and men when they're facing racial trauma is that we often treat boys as men. The adultification biases that we're referring to lead sometimes to the tendency to view some children as less innocent and more adult-like. And in fact, numerous studies have shown that Black girls and boys are often viewed as more adult than their non-Hispanic white peers. And we know that this adultification is linked to harsher treatment and higher standards for Black students in schools. But we also know here that biases like these can impact expectations around trauma severity, recovery, and response, such that we expect boys and men of color to leap over structural disadvantage and systematic dehumanization in a single bound. And those kinds of expectations can limit our capacity to truly see them. This quote from Ava DuVernay's documentary is particularly striking and relevant to our conversation today. This quote, lifted up by one of the characters who played Raymond Santana, is as follows. "They say boys will be boys. They're not talking about us. They don't mean us. They mean other boys." So in this country, there is a significant empathy gap in our capacity to see boys and men of color as vulnerable and worthy of cover and protection. And we know that boys and men of color face unique racialized stress, even in the midst of this pandemic, that can compromise social emotional well-being and increased trauma risk. We know, for example, as we've been discussing today, that racism has fatal consequences for Black boys and men. And over the past 50 years, Black men have faced significantly greater risk of being killed by police than white men. These are data taken from a study conducted by researchers at Harvard, led by Dr. Nancy Krieger. And during the pandemic, we also know that while sheltering in place, our children, particularly our boys and men of color, across the spectrum of communities of color, are bearing witness virtually to these events. And this repeated exposure can contribute to the kind of secondary or vicarious trauma and subsequently impact learning and academic achievement, and therefore impact opportunities for upward social mobility. In our attempts to provide supports for boys and men of color in this moment, it is important that we move from trauma-informed towards a healing-centered approach. A trauma-informed approach is defined as a program, organization, or system that realizes the widespread impact of trauma and understands the potential paths for recovery. In contrast, a healing-centered approach is more holistic. It involves culture, spirituality, civic action, and collective healing. A healing-centered approach helps boys and men of color discover that they are much more than the sum total of their traumas. In order to enact a healing-centered strategy for boys and men of color in the face of COVID-19 and in other circumstances, we need to focus on meeting unmet social determinants of health needs, because we know that the kind of racism and discriminatory practices that we're seeing unfolding in this moment are actually operating in the places where men and boys live, work, play, pray, get health care, and get educated. We need to shift our focus away from siloed work and create multi-sectoral alliances and partnerships that are healing-centered. We need to be aligning our strategies, amplifying collective impact, increasing and leveraging and coordinating investments, and more importantly, enhancing youth and community-led policy action so we do nothing about them without them. In the state of Connecticut, at the UConn Health Disparities Institute, we are creating healing-centered communities for this very purpose, which include arts-based strategies that recognize that art has the potential to meet people in the heart space and perhaps bridge those empathy gaps and visibilize communities that are invisibilized by systematic dehumanization. We are centering and amplifying community voice in these artist and scholar conversations and hosting community-led gatherings so that people can truly see boys and men of color at their fullest potential. We are also creating healing center communities by entering schools and having conversations with boys early in the life course about trauma, about emotional expression, and about healthy enactment of masculinities. And we are also creating brave new spaces for racial trauma, healing, and recovery so that we center the youth in our community in the policies, actions, and practices that we enact. We are asking youth, what do you need to be healthy, to be free, and to experience a just world? And when we listen to them, when we see them, we hear them telling us exactly what they need. They're telling us that they are trying to take off the various masks that society has required them to wear and to stand in the fullness of their humanity. And to meet them where they are at the highest levels of their healing intentions, we have to speak to their wounds. And in this way, I'm hoping that in our discussion, we can talk about how we optimize these supports. And I offer these examples. The first is to hold space, as we're doing here today, for emotional expression, to move from trauma-informed to healing-centered mentoring pedagogy, to actively fight and dismantle systems of dehumanization, to leverage our privilege, and most importantly, to display radical empathy, radical hope, and agape love. I'm leaving my contact information here just a second while we transition to Dr. Smedley, and I'd like to thank you for the opportunity for sharing this information. At this point, it gives me great pleasure to welcome Dr. Brian Smedley to the stage, and it's really great to have him round out our conversation today because he's been leading the American Psychological Association's efforts around flattening the curve, and his campaign, Equity Flattens the Curve, is really a motivation, in fact, for this conversation. So thank you so much, Dr. Smedley, for sharing your time, your wisdom, and expertise.
Thank you, Dr. Powell. I'm very honored to join this wonderful panel. I've learned a lot already. Can I ask that the team kindly bring up my slides for me? I would appreciate that. While you're doing that, it's important to note that the issues of intersections between gender, race, ethnicity, immigration status, these are all critical conversations that we have at this point. The basic point of this presentation is that we know that historically, pandemics and epidemics tend to elicit fear, distrust, anxiety, which in turn leads to a heightened risk for otherizing, marginalizing, and for expressions of racism, xenophobia. We've seen that very clearly with xenophobic and racist attacks against Asian Americans, a point I'll return to shortly. And that is the goal of Equity Flattens the Curve, to center equity in the conversation about pandemic response, to make our communities aware that even as we're physically distancing, it's critically important that we build cohesive communities, that we come together socially to show solidarity, to create communities and spaces where equity and inclusion are paramount, because that is as important as physical distancing to get on the other side of this pandemic. So next slide, please. APA has a long history of work to address the needs of boys and men of color. In 2015, for example, these are just recent examples. In 2015, APA co-sponsored a conference on pathways for behavioral health equity, addressing disparities experienced by boys and men of color. In 2018, a robust panel of distinguished leaders chaired by Dr. Powell and also including Dr. Griffith, released Health Disparities in Racial, Ethnic, and Sexual Minority Men and Boys, really thoroughly examining issues of race, ethnicity, sexual orientation, gender diversity, and their intersections. And of course, in 2019, APA released guidelines for clinical practice with boys and men of color. Next slide, please. I wanted to elevate a quote that Dr. Powell has offered that I think is so true. Despite the odds stacked against them, the majority of vulnerable boys and men are resilient and oriented toward positive growth. It's critically important that we recognize this. And we see these great sources of resiliency and strength during this time of pandemic. As has been noted earlier, we are seeing a coming mental health tsunami as a result of isolation, distancing, as a result of economic anxieties, anxieties about personal or family risk for contracting the virus. So it is important to note that sources of resiliency, particularly in communities of color, are helping people to actively and healthily cope with some of the challenges that are faced. And indeed, boys and men of color are critical. And it's critically important to recognize the sources of strength and resiliency that they bring to their families, to their communities, and to themselves. So it's important that we come at this problem not from a deficit orientation, but from an orientation that recognizes inherent strengths and wisdom in communities that have been historically marginalized. Next slide, please. So COVID-19 is elevating the fact that we are a deeply inequitable society. We have been a nation racked by racial inequality, gender inequality, class differences that are widening, and the pandemic, of course, is exacerbating these experiences. We've seen Asian Americans targeted by hate speech and actions in both public and virtual spaces. I'm going to come back to this point shortly because I think we all bear a civic responsibility to marginalize those voices of hate that are being expressed at this time, and to call out leaders who would foment hate and distrust, because again, these are the kinds of characteristics of societies that do not fare well during pandemics. We've seen many communities of color at greater risk for infection and mortality, as has been pointed out. But these communities are often lacking the financial, linguistic, and geographic access to appropriate health care that they would need, particularly if they should contract the virus. These communities disproportionately work in essential and often low-paying jobs. This is particularly true in some of the sectors where we see significant gender and racial segregation. So I'm thinking here about nursing home attendants, disproportionately women, immigrants, women of color. When we think about men, particularly men of color in frontline jobs where physical distancing may be impossible, we have to recognize the persistent racial and gender segregation in our workforce that indeed exposes many, particularly men and women of color, to health risks. And it's true that media reports have tended to focus on racial and ethnic disparities in terms of infection rates and mortality rates, and they have in some cases pointed out that this is because of the higher risk for chronic conditions in these communities, but they've often left the reporting there, which creates an opening in the minds of most Americans, I would argue, for negative stereotypes and myths about health disparities to emerge in their minds. Myths that somehow these disparities are tied to somehow differences in biology or genetics across racial and ethnic groups. We know, of course, that that's not true, and geneticists themselves have debunked those myths. There's greater genetic variability within so-called racial groups than between them. And race itself is, in fact, a social and political construct unique here to the United States. Those notions are not found in places like South America, where there are much finer grained distinctions. The commonality, of course, is that it is skin color and physical appearance by which people base judgments about the value of human life, whereby darker features are associated with lower human value. So educating these audiences about the structural inequities that cause them is important. We see higher rates of chronic conditions in communities of color, not solely because of a lack of access to healthcare. A lack of healthcare did not produce these inequities. Rather, social, economic, environmental conditions created these inequities, and much more specifically, the persistence of racism at structural, institutional, interpersonal, and internalized levels is why we see higher rates of chronic conditions in communities of color, and the media needs to do a better job reporting this. Next slide, please. So why equity flattens the curve? It's clear that the health risks, burdens, and experiences and outcomes related to the pandemic are not the same for everyone. Communities of color, immigrants, many others bear a heavy, heavy burden from this pandemic. So to flatten the curve, we've got to tackle the racism, stigma, and discrimination that's at the root cause of these inequities and ensure that strategies and solutions are delivered equitably. This is why we say it's important to center equity in the pandemic response, and leaders at all levels bear responsibility for carrying that out. Next slide, please. So we have engaged audiences in this campaign, Equity Flattens the Curve, using the best of our psychological science. We're trying to help key audiences, including elected officials, community leaders, journalists, understand the health and mental health needs of stigmatized populations. If we had a problem with lack of access to mental health care in particular, and stigma about seeking healthcare services in some communities previously, that's going to be only exacerbated now. We need to do more to increase access to needed services and reduce stigma. We need to help audiences understand how bias, stigma, and discrimination complicate the pandemic response. As I said earlier, divided communities are those that are not going to fare well during the pandemic. We need social cohesion and a greater sense of collective efficacy to help ensure that we flatten the curve. We need to help communities build social cohesion and tolerance, even as we're physically distancing. It's our hope that we can use this crisis to help our nation understand the deep harm that's caused to all of us by our destructive social hierarchies, be they racism, sexism, xenophobia, transphobia, homophobia. All of these sources of inequity result from these attitudes about human hierarchy and the belief in differences in human value. We've got to hold a mirror up to the nation to help us understand that particularly during a pandemic, and even once we get out of it, it's important that we be an equitable, inclusive society if we're going to survive together. Our fates are deeply intertwined, and we need to recognize that. Next slide, please. We have 4 goals. If you don't mind going back, please. We have 4 goals associated with Equity Flattens the Curve. The first is to connect the voices of a diverse group of individuals from health equity, public health, psychology, behavioral health, to educate policymakers and leaders regarding equity-enhancing practices and policies. We seek to reduce bias, stigma, and discrimination related to the pandemic. So, for example, as was alluded to earlier, there is evidence emerging that there are disparities in access to COVID-19 testing and treatment. And we know from a large body of literature that racial and ethnic minority patients are less likely to access needed health services, not because of failures on their part in terms of behavior or attitudes, but because of structural inequities. We still have healthcare systems that remain separate and unequal, the phenomenon of medical apartheid. And we know that bias can emerge in the clinical encounter, which leads to disparities in access to needed healthcare services. Psychology has a lot to offer to mitigate that problem. We seek to promote social cohesion, inclusion, and equity as necessary to mitigate the virus's spread for all the reasons that I said earlier. And importantly, we need to promote policies and practices that reduce inequity and address the public health needs of diverse populations, near-term and long-term. So we are following federal legislation, for example, that could further expand federal and state safety net programs around housing assistance, food assistance, unemployment insurance. These are all critically needed, and particularly so for marginalized populations, again, to take care of their needs and to mitigate their risk during this pandemic. It's also true that we need much better data collection and reporting. Currently, the data collection and reporting on the pandemic is woefully inadequate. There are a handful of states that are reporting comprehensive demographic data, but still to this date, most are not. And even among those states where we have demographic data reported, there's a large share with missing data. We simply cannot have that. We need to know where inequities are happening in terms of access to testing and treatment. We won't know this unless we thoroughly and comprehensively collect demographic data such as race, ethnicity, gender, nativity, primary language, etc. And that will help us to understand where and when disparities are occurring. And even more importantly, it will promote accountability on the part of those elected leaders and officials, healthcare system administrators, who need to be held accountable for equity in terms of who gets access to these needed resources. Next slide, please. So we're doing a number of things with Equity Flattens the Curve. If you email us at eftc@apa.org, you can join us. We're conducting a series of activities and campaigns designed to connect our voices. We're creating a virtual resource and capacity building center to share evidence, strategies, toolkits for action. And we're educating and activating individuals to stand up against bullying and marginalization. Next slide, please. Okay, that is my last slide. So again, I invite you to join us at eftc@apa.org. Join us on Twitter using the hashtag #EquityFlattensTheCurve. We're having rich conversations, and it's been very important to see this interdisciplinary group with diverse identities come together to unite our voices, to insist, to demand that equity is a central focus of our pandemic response. Thank you so much.
Thank you so much, Dr. Smedley, for that really, really, I mean, just inspiring presentation, because I think it gives us as a group of psychologists and folks who are working in this space instruction, but I think our viewers hope for efforts that we can, strategies and responses we can mount to flatten the curve by centering equity. So important. I want to pick up, we have had some questions in our Q&A, and I'm going to try to combine these in the interest of time. But one question I think is really important, and perhaps on the minds of the psychologists who are watching, is how can we help psychologists recognize their own unconscious biases, right, in a way that actually puts them in a better position to support boys and men of color and work towards reducing disparities and flattening the curve? And this is the question I'll pose first to you, Brian, since you have the mic at the moment, but I would invite our other panelists, Dr. Levant, Dr. Wong, and Dr. Griffith, to weigh in also.
Thank you, Dr. Powell. And I would invite our panelists to turn their cameras on so we can see each other as we enjoy this discussion. Psychologists and mental health professionals and all health professionals need to fully understand potential biases that they might have. I mean, we've recognized this in the field of psychology for decades now. All of us, if we have been socializing in the United States and many other countries around the world, have social hierarchies embedded in our brains. We are not consciously aware of them in many cases, but they are nonetheless there. We have to actively work to surface biases that we may have and to actively work to decouple those thoughts that are automatically linked to difference that we experience. So when we experience difference across lines of race, ethnicity, gender, nativity, our brains are automatically triggering responses that we're not consciously aware of. We need to surface those automatic responses, bring them under control, and help us to understand how we experience difference in the world.
Thank you for that. Dr. Griffith.
Yeah, just to pick up on that, that was kind of why I made the point about rethinking the frame. And, it really is important. I guess the most concrete strategy I can say is to challenge yourself to explain more critically, where are you coming up with this explanation for why there are these disparities? Why is that person there? And is that a valid reason as to, do you have some actual support for the explanation that you have? Have you checked in with that person to see if whatever stereotypes you may have of that particular group actually applies to that particular individual. I mean, we know that that's the nature of the way that stereotypes work, is you have these assumptions, beliefs, and so forth that may be true or generally applicable to a broad group, but don't necessarily apply to an individual when you see them. So I think really pushing yourself to think, what's going on with the person in front of me, what's going on with the populations that I see, and how do I understand and explain? And then what are the data that supports the explanation that I have? And what are the things that may be challenging that explanation would be important places to start.
I think that's really important, Dr. Griffith, because as a field, our orientation, our training teaches us that we are focused on the interior life, right? Like we should be self-aware, and so it's sometimes harder for us to see as psychologists that we have those biases, right? We think they operate out there, right? And not in our field, and yet they do. Dr. Levant, what would you like to say?
I think the challenge that I would pose to us is how to find a way to talk to men about how they can be men without being masculine. The masculinity, and I think this cuts across all races, is a health risk factor in so many ways. So many of the norms are directly connected to behaviors that put men's health at risk. And as Division 51 has found when it releases guidelines on psychological practice with boys and men, we elicited an enormous backlash because many people misinterpreted what we're saying and thought that we were saying boys and men are bad. People in the people we want to reach don't separate sex from gender. They don't understand that masculinity is a socially constructed set of social norms independent of the Y chromosome, and that people have choices as to the degree to which they conform to or resist these masculine norms. And that is the challenge that I think we have to get some better grip on, really, to kind of have a conversation in the public square with, ordinary men.
Yeah, I mean, I think your point about what you're lifting up for me, Ron, is that the biases also that we're talking about that shape the racialized lives or experiences of people of color are also working in tandem with biases around men that sometimes clinicians hold about men being strong and tough too, right? Like in the expectation around how they might even respond to the psychosocial threats that are produced in the pandemic and otherwise. And so getting a grip on how we are thinking about men as gendered beings, I think is an important, and in this case, racially gendered beings is important, or ethnically gendered beings is important.
Yes.
Joel,
Yes.
Dr. Wong, do you want to jump in here? I saw you unmute your mic.
Sure, yeah. Just want to offer two practical suggestions in terms of reflecting on unconscious biases. The first is, if you're on the internet, just search for implicit association test. Now the test is not perfect and there are all kinds of arguments back and forth, but I think it's just a useful initial start in just exploring at the automatic level, what do you associate a particular racial group with? Just try it out. Implicit association test, it's free. Just check out and it'll give you a kind of assessment results. The second suggestion I have is to do an audit of who do you tend to hang out with? Who do you tend to, what kinds of activities do you tend to focus on? Because I want to argue that one of the most insidious forms of bias and discrimination is discrimination by omission. So in other words, it's not an active form of discrimination, it's you're omitting to show favors to one group and you're favoring one group over the other, and not in a very obvious way. So, if I want to hang out with people, if I want to get to know some people, do I tend to gravitate towards a particular racial group when I think of who to call to hang out with? Or do I tend to just avoid certain groups? I think that kind of audit and kind of would give us an honest assessment about discrimination by omission.
That is such an important point. One of the things that we've been talking about in this moment is, the calls to action that have gone out. I mean, we've seen, many statements that have been offered and written and circulated from every vortex of society. And in some ways that's inspiring, but on the other hand, the question has been raised, are you willing to subject your organization and yourself to a forensic examination of bias, and sort of exercise out of the systems of practice, out of our policies and procedures, the racism that lives and breathes there, like carbon monoxide, right? So are we willing to do that? And, as we're talking about this issue around implicit bias, one of the questions that has been raised as we're talking about the wicked problem, of these shadow pandemics, and also the very real pandemic we're dealing with respect to COVID-19, is that we're trying to figure out how we get, folks to think about working with law enforcement, and if that's even a viable strategy, right? So is it a viable strategy, for example, for psychologists to think about partnering with law enforcement around their own biases, right? Because we know they hold them, and those color the ways that they interact with men in public space, particularly Black men who are wearing masks and are now afraid to like be out in public. Is that a viable sort of structural intervention? And I'll direct this question specifically to Derrick and Brian, but I would also like others to weigh in, because Derrick has written a lot about structural interventions, and probably the most eloquently, I think, about structural interventions that I've read. So I really would love to have the two of you weigh in. Dr. Griffith.
I think it's a wonderful question. I think I think one of the key points that I don't want to miss in what you're describing is to identify the ways that racism is gendered. And we don't tend to pay attention enough to the ways that the stereotypes that even Dr. Wong was talking about through his framework, the way that these different factors are really affecting the way that we understand the experiences of people, and that a lot of times these nuances are missed, and what that raises in those groups and the culture that sort of it breeds gets missed in that larger conversation. As far as working with the police, I think it really, it's kind of like community-based work in the sense that you have to have a certain temperament, you have to have a certain skill, you have to have a certain way to, it's not for everybody, I guess is my point. In a very pragmatic sort of sense, you have to know what you're getting into, and you have to be really willing to be patient with the culture of the organization, and realize that regardless of the body and the characteristics of the individual that you're maybe looking at, that they're responding to the larger culture that shapes that organization. So you can't just isolate the individual within the organization. You have to look at the larger context of what's shaping what they're doing. It's within their body of their particular organization, but it's also what are police, what are the expectations and norms that are set within that job sector, within that community, both in their lives individually as well as in their professional lives as well. So I think it's really recognizing and not judging, but you have to be willing to really see them and understand where they're coming from, to then, offer some both empathic as well as thoughtful response to help, work with them in that space.
Thank you, Dr. Griffith. Dr. Smedley.
I would totally agree with what Dr. Griffith said. It's inspiring to see new models of community safety and emerging that are very grassroots based, and I'm very hopeful that we'll be able to evaluate some of these new models to see how effective they are. But I also just wanted to pick up on what you said, Dr. Powell. We've got to be working upstream. We've got to be thinking at the level of systems, structures, institutions. To the point that Dr. Levant raised earlier, the reason why people of color disproportionately live in food deserts and communities that are overrun with environmental degradation, et cetera, is because of residential segregation, fundamentally. Communities of color are, to no fault of the residents who live there, overwhelmed with a plethora of health risks, while often lacking access to health-enhancing resources. I'd love to see our discipline more engaged in the fight around segregation as we once were when Dr. Kenneth Clark's seminal research helped to inform the 1954 Brown v. Board of Education decision.
Very true. I'm wondering if and Ron, I'm going to let you come in just a second, but I want to give our panelists an opportunity to think about my final question before I come to them. And the final question I'm going to pose to everyone on the panel is, how do we hold space for boys and men of color now in the midst of this COVID-19 pandemic? Given all that we've described today, if you had a single message that you could give to the audience around holding space for boys and men of color in this moment, what would it be? So just think about that, and I'll get Ron's point, and then we'll go around and get your responses.
Okay. Well, I think in terms of the police department, I've actually been thinking quite a bit about this. You know, most police departments have and you were talking about the culture, they have a hyper-masculine culture. They are overwhelmingly composed of white men. So based on Gordon Allport's famous contact hypothesis, the first thing that I would recommend is that we, radically diversify police forces. Bring in women, bring in people of color, bring in openly GLBTQ people to kind of, dilute that masculinity culture. And then secondly, I think we should take interventions like Jim O'Neill's gender role journey to police departments to, kind of give police an opportunity to examine their assumptions about masculinity and whether that is the only way they would want to function as police officers.
Those are really great suggestions, Ron. Thank you so much. And so I want to, let me start with Dr. Wong and get a response to the final question for today's conversation around what can we do in this moment to hold space for boys and men of color.
Sure, I just want to share one simple practical suggestion, and it's something that needs to be done at the macro level too, not just at the micro level, which is that the media needs to highlight and showcase the hidden voices of boys and men of color. We really need to take an intersectional approach and not just talk about how the pandemic is affecting people in general, but specific subgroups, so I think boys and men of color, how they're experiencing the experiences of discrimination, the experiences of health disparities, that needs to be given much more attention in the media.
Absolutely, thank you. Dr. Griffith.
I think the two quick things I'll say is make space to listen to them. I think that's about the simplest thing I would say. Is, make space to hear what they're grappling with, what they're dealing with, what they're feeling, what they're thinking, and have conversations where possible to explore, to challenge, to support, encourage, whatever it is that they're dealing with. The other thing I would do is be cautious of the media consumption. I think a lot of people are experiencing a lot of fatigue just with the volume of particularly with the protests and so forth, and just the volume of information and the volume of stressing, racism and that we're seeing, and even the positive responses to it. But it's exhausting. And for people who younger people particularly, who may not have the exposure or experience, the language to understand it, that, giving space to that is going to be really important. So I would be cautious to overexpose them to that kind of media and try to, have some conversations explicitly about it.
You're muted. I can't hear you, Wiz.
So sorry about that. Thank you for that. Dr. Smedley.
I would just say simply, we need to celebrate and uplift boys and men of color. It's been kind of funny to see high school and college graduates finding innovative ways to celebrate their accomplishments and achievements. I think every community needs to do the same to celebrate and honor our boys and men of color.
Thank you so much, Dr. Smedley. And we recognize that this is the first of many conversations that we need to have around these topics, and we try to entertain all of the questions, but I think we're going to be thinking together collectively in our division and alongside APA about how we can collectively hold space for boys and men of color and work to create a more diverse, just, and equitable world. While we're doing that, we invite you to continue to follow along with our initiatives around holding space for boys and men of color. We invite you to use the hashtag Equity Flattens the Curve and the hashtag Holding Space for BMOC whenever talking about or sharing your reflections about this conversation. We hope that you'll stay in touch with us and that you'll join us in our efforts to create brave new spaces where boys and men of color can heal, grow, and thrive. Thank you for joining us for this cool conversation, and we look forward to collaborating with you in the future. Take care, everyone.